This is Pick Your Poison. I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. Want to know how you can be poisoned by a Civil War artifact? What movies always get wrong about gunshot wounds? And what toxin has been implicated in the fall of the Roman Empire? Stay right here to find out. This is an interactive story. Will our patient live or die? It's up to you and the choices you make. Your phone is ringing, so let's get started. Today's episode starts with a phone call. It's your cousin shouting frantically into the phone. You can't understand a word she's saying. After several minutes, you finally gather her child, a 3-year-old, is sick. He's so lethargic she can barely wake him up. The phone conversation is not making any headway and the child doesn't sound good. Rather than try to get more information on the phone, you tell her to meet you in the emergency department. In real life, of course, you probably wouldn't take care of a family member, but this is fiction, so you're the doctor. In the emergency department, you enter his room. Your cousin is sitting on the stretcher holding the child in her arms. He doesn't move or even open his eyes. You get a gown and ask her to get him undressed. He doesn't really react as she does that either. The nurse tells you the vital signs are as follows: temperature 98.6 Fahrenheit or 37 Celsius, heart rate 120 beats per minute, blood pressure 90/45, respiratory rate 25, with an oxygen saturation 100% on room air. Essentially normal vital signs for a 3-year-old child. This is not the child you just saw 1 week ago at the family Labor Day party, running around and jumping off the diving board. That child probably would have been jumping off the bed and racing around on the stool. The family was gathered at your grandfather's house. The kids enjoyed the pool. Your grandfather showed off new additions to his collection of Civil War memorabilia and reminisced about his reenactments at Gettysburg to anybody who would listen. He told you stories about hospital tents with piles of amputated limbs, all cut off without the benefit of anesthesia. Is this true or false about the lack of anesthesia? That's question number 1. A, true. B, false. Actually, this is false. Contrary to public opinion of the limbs being sawed off with men biting on leather straps, in most cases, anesthesia was used in surgeries during the Civil War. Anyway, you asked Mom what happened to the patient. She said the day following the party, he complained of abdominal pain. She thought he'd probably eaten too many sweets. He developed constipation a few days later. She took him to see the pediatrician, who didn't find anything worrisome. Mom thought he was coming down with a virus until this morning. Not only did he not wake her up at 6 a.m. as usual, when she went to wake him up, he was extremely lethargic and barely rousable. That's when she called you and brought him to the emergency department. She says he's not had a fever, no cough or congestion, no runny nose, no vomiting or diarrhea. No one in the house is sick. He's not having pain with urination. He has some bumps and bruises because he's a rambunctious child, but he hasn't had any significant traumatic injuries like a fall. Doesn't take any medicines other than the stool softener she gave him a few days ago, and has no allergies to medicines. You ask if he could have gotten into any medicines in the house. She says it's unlikely as they're stored in medicine cabinets which he can't reach. You have some skepticism about this, seeing the way he was climbing fences at Grandpa's house, but that said, even if he could climb up on the counters, she probably would have noticed spilled or open bottles of medicine if he'd gotten into something. You move on to the physical exam. The patient is extremely lethargic. He doesn't even open his eyes as you examine him, and even when the nurse puts in an IV, he gives only a short, weak cry. There's no external evidence of head injury, meaning no bumps or cuts on his head. His neck is normal. There's no stiffness. His pupils are equal and reactive to light. His heart and lungs are clear. He grimaces a little when you press on his abdomen. He is able to move all of his extremities, though he's very weak and barely able to lift them up off the bed against gravity. All right, so what do we do now? Despite him having normal vital signs, this is a pretty worrisome case because he looks very sick. One of the things you can never forget about pediatric patients is that they can look relatively well and suddenly crash, meaning their vital signs look good until they look awful. And this is because most kids have strong, healthy physiology, so in most cases they can compensate for a lot of problems until it's too late. The nurse holds up the tubes of blood she's drawn and asks what orders you want. Certainly basic labs, as well as a lactate and blood cultures to look for infection. A chest x-ray and urine specimen would be important for the same reasons. It might be worth doing flu and COVID swabs, not because this is likely, but to exclude them as possibilities because somebody will ask you to later. What about a head CT, did I hear you say? Good question, and you'd have to debate the pluses and minuses. In an adult, we'd probably order one. In children, we try to be more cautious about radiation exposure. If you want the head CT, I don't think that's unreasonable. I might wait until we have some basic labs back, but Either answer is right at this point. It's a difficult case. We have a definitely abnormal child without a lot of history or physical exam findings to point us in the direction of what's causing this. You're pretty worried, both as a family member and as a doctor, about this kid. You call pediatrics, who agrees with your management so far and says, let's get the results back from the initial tests, and then we can consider a head CT and a spinal tap if nothing else turns up. You hang up the phone and move on to your next patient, the victim of a dog bite with a serious laceration. You're halfway through stitching the laceration on the woman's leg when you hear a commotion. You ignore it, trying to stay focused on the procedure. A colleague puts their head in and says, sorry to interrupt, I know you're suturing, but the 3-year-old is seizing. Do you want me to order some benzos until you finish? Your fist clenches around the needle driver in your hand. This is not a good development. Yeah, you say, thanks. You tell him the child's weight so he can dose the medicine appropriately. You finish up the last 4 stitches, apologize to the patient, and run back to your cousin's room. Your colleague had ordered intravenous lorazepam, i.e. Ativan, and by the time you get to the room, the seizures stopped. If you listened to the last episode, we talked a lot about seizures, so I'm going to keep this very brief. Seizures are definitely not uncommon in pediatric patients. Febrile seizures are actually really common, but he didn't have a fever, so that's not likely. Certainly, people can have new onset epilepsy. Epilepsy doesn't explain him having been sick for several days. What about something like meningitis or encephalitis? No fever, no stiff neck. Mom says he's vaccinated, which dramatically reduces the risk of bacterial meningitis. As we said before, you can have encephalitis with all of these findings. It's a possibility. That's why the pediatrician mentioned a spinal tap. Now you do want to get the head CT if you didn't order it before, and you ask the nurse to expedite. But this isn't a neurology podcast, it's a toxicology podcast, so let's get right to potential toxins. Again, we discussed this in the last episode called Short Circuit. The bottom line, there are tons and tons and tons of toxins causing seizures. In fact, if you've listened to any episode whatsoever, you probably know that the endpoint of many toxins is seizure, coma, and death. And you don't need me to tell you that kids can get into all sorts of stuff at home. Mom doesn't think he got into anything, but in a case like this where we have no idea what's happening, it's worth asking what medicines are in the house. You ask about prescription medicines, she says no. She and her partner don't take anything. There are no illicit drugs in the house. He hasn't gotten into any alcohol. And that's a good reminder of something we need right away, a finger stick to check to make sure he doesn't have a low blood sugar. The nurse tells you it's normal. What about over-the-counter medicines, you ask? She says they have acetaminophen, i.e. Tylenol, ibuprofen, i.e. Motrin, diphenhydramine, i.e. Benadryl, and melatonin. Next question. Could this be an overdose of one of these over-the-counter medicines? Could it be the A, acetaminophen, B, ibuprofen, C, diphenhydramine, i.e. Benadryl, or D, melatonin, or E, none of the above? The answer is E, none of these fit exactly. Melatonin does come in gummy form, making it appealing for toddlers. He's lethargic, which goes along with that. There's a little debate about melatonin causing seizures, but it typically doesn't do so in overdose. Also, it's short-acting, so it wouldn't have made him sick for several days. Acetaminophen causes liver failure and ibuprofen nausea and vomiting, not seizures. What about diphenhydramine? Well, this is a good thought because it definitely causes seizures, it definitely causes lethargy. But what's missing, though, are the other features of anticholinergic toxicity in our patient. He doesn't have a rapid heart rate or a high blood pressure. Other things causing seizures, I hate to list cocaine and methamphetamine as household items, but sadly that is the case in some places. Children can get into them and have a seizure, but again, the vital signs don't work, and you really don't think your friend and her partner are using drugs. Organophosphates like pesticides, but the vital signs aren't right. Essential oils can definitely cause seizures, but she says they don't have any of these in the house. As the nurse wheels the toddler down to radiology, you sit at your computer and scroll through his results. The lab work is unremarkable, there's no sign of infection. Electrolytes and liver and kidney functions are normal. There's no sign of infection in the urine. You pull up his chest x-ray to check for infection there, and after the image loads, you suck in a sharp breath. Since he's a small 3-year-old, the x-ray caught the upper part of his stomach, along with the answer to this case. There's a round object in his stomach about the size of a quarter. It's time to pick your poison. Do you think this is A, lead toxicity, B, toxicity from a magnet, or C, button battery toxicity? The answer is A, lead toxicity. You have an idea about what the toxin is before you can identify what's in his stomach. This is specifically acute lead toxicity, which fits with his symptoms. Button batteries cause burns in the esophagus and gastrointestinal tract, which doesn't fit. Magnets are toxic if more than one is swallowed. They can click together inside and cause bowel obstruction or necrosis of the bowel wall. Dangerous, both of them, but they don't fit here. Your cousin's symptoms fit exactly with lead toxicity. Now, this is a huge topic, especially in pediatrics. There are pediatricians, toxicologists, and all sorts of other experts who devote their entire careers to treating and researching these topics. I want to try to keep this succinct and stay on track because I want to talk about some really cool historical stuff in the Roman Empire related to lead in a few minutes. So first, there's acute and chronic lead toxicity. Our patient has acute toxicity, but chronic lead toxicity is a lot more common, and so I want to say a little bit about it. This is when patients get exposed from, say, eating paint chips. The symptoms can be very insidious, occurring slowly over weeks to years, and it can be very difficult to diagnose. It's even difficult for parents to tell the behavioral changes are abnormal. So this is the reason why pediatricians screen for lead levels on a regular basis. In addition, you can see abdominal pain and constipation. It causes anemia, a low blood count, but what we really worry about and the reason that we screen for it are neurocognitive changes that lead exposure causes, meaning changes in the brain. Children with chronically elevated blood lead levels can lose up to 9 IQ points. They're 6 times less likely to be able to read and 7 times more likely to drop out of high school, which is pretty astonishing if you think about it. They're 2 times more likely to have ADHD, and these behavioral changes persist even into adulthood. Adults are more likely to have a lower socioeconomic status and more likely to be arrested for crimes. So screening is one of the many, many really important things that pediatricians do for their patients. Okay, but this is acute lead toxicity, as I said, and this happens over days to weeks rather than months to years. Similarly, it can cause abdominal pain and constipation. Anemia is less likely because the anemia takes longer to develop. What we worry about with acute lead toxicity is high lead levels causing lead encephalopathy. What's that? Encephalopathy basically means a problem with your brain. With lead encephalopathy, specifically, children become lethargic and can have an altered mental status. They can have seizures, and ultimately coma and death can occur. Unfortunately, your cousin's symptoms fit exactly. You don't know what that foreign body is in his stomach, but you're willing to bet it contains lead. You order a blood lead level, which in most hospitals will come back in a few hours. An hour later, you get his results. His blood lead level is 100 micrograms per deciliter. You suck in a breath when you see it. This is extremely dangerously high. A normal blood lead level should be under 5, and we worry about effects of toxicity at a level even of 10. So what do we do now? Well, there are 2 things we need to accomplish. First, we need to remove the source of the lead toxicity, and second, we need to treat the lead exposure that's already occurred. You call the pediatric gastroenterologist who listens at the case, takes a look at the x-ray, agrees, and says they'll do an emergent endoscopy to remove the foreign body from his stomach. So we can move on now to number 2. We need to treat the lead that's already been absorbed into his body, reflected by the lethally high lead level. How do we treat toxicity? That's question number 3. Is it A, an antidote, B, chelation, or C, dialysis? The answer is B, chelation. We don't have a specific antidote for the treatment of lead, but we can chelate the lead out of the body, and this actually works pretty well. Dialysis in general is not good at removing heavy metals. What exactly is chelation? Well, it's when you give a medicine that can bind to the heavy metal, thereby inactivating it until it's excreted from the body. You could imagine it as sort of a cage surrounding the lead and keeping it from binding to anything and causing further damage. The treatment of lead toxicity is another huge topic we could spend multiple episodes on, and again, I'm going to sum it up with some generalizations rather than get into the weeds and bore you to death. First, there are differences between treatment recommendations between adults and pediatrics, and second, different types of chelators are available in different countries. For example, there are differences between what's available in the US and Europe. Blood lead levels are one parameter to determine the treatment of lead toxicity because it does correlate pretty well, and the second parameter are symptoms. So patients who are more symptomatic require more intensive treatment than those who are less symptomatic. Focusing specifically here on children, a mild elevation of the blood lead level is considered a level under 50. You can expect some mildly impaired thought processes, some subtle changes in behavior, and fine motor skills. Moderate elevation is generally between 50 and 70. You can see impaired hearing and impaired growth, irritable behavior, decreased interest in playing, and intermittent abdominal pain and vomiting. Levels above 70 are considered severe. This is the range where we become concerned about encephalopathy, manifested as altered mental status, bizarre behavior, loss of developmental skills, seizure, and coma. In chronic toxicity, you get anemia at this level. As I said, we take both the level and the symptoms into consideration. If the level is under 45 and the symptoms are mild, then the treatment is really to remove the lead, whether it's stopping the child from eating paint chips, removing them from an environment where the lead is high in the soil, etc. At levels of 45 to 69, they are usually treated with oral chelation. In the US, this means a medicine called Suxmer or DMSA. And for levels above 70 or children with severe symptoms, definitely with encephalopathy, we treat with both an intravenous and intramuscular chelator. In the US, this means calcium disodium EDTA given intravenously, as well as dimercaprol, also called British anti-Lewisite. I'll tell you why in a second, it's actually pretty cool, given intramuscularly. Does chelation work? Yeah, it actually works so well that the combination of the two drugs can drop lead levels by 50% in just 15 hours. And over the course of 2 to 3 days, it'll drop by 75 to 80%, which is pretty amazing if you think about it. Just for reference, in adults, we typically don't treat blood lead levels under 70, since adults' brains aren't changing as much. Higher levels can be tolerated in the short term. So this sounds great, right? It sounds pretty easy. But I have to tell you that chelating patients with lead toxicity is a lot harder in real life than it sounds like in textbooks. First, Suxmer smells like sulfur. So people don't want to swallow it, then it makes them smell like rotten eggs, so they hate taking it even more. And they have to take it for at least days, sometimes weeks. This can result in patients not taking it as prescribed, causing fluctuations in blood lead levels. Think that's bad? Well, dimercaprol can be even more difficult. From a pharmacologic standpoint, it's very difficult to dissolve, so they use a thick, oily peanut oil to dissolve it in. This means it can't be given to patients with peanut allergies. It also means it has to be given as an intramuscular injection, meaning the person has to get a shot every 4 hours for days. Adults don't love this, and you can imagine giving a pediatric patient a shot every 4 hours. Another issue that always confounds toxicologists and pediatricians when treating blood lead levels are fluctuations. These occur frequently for several reasons. The first is re-exposure, so sometimes a person's admitted to the hospital treated, the blood lead levels go down, they're discharged to continue Suxmer at home, but if the exposure wasn't identified, or if it was misidentified, they might be re-exposed if it's coming from the home or the workplace. But even if the exposure was removed, blood lead levels can still go up, even if the patient is taking the medicine exactly as prescribed. Why? Well, there's something called the lead sink in the body. And what is that? That's question number 4. Is it because A, lead continues to be absorbed from the stomach, B, someone is poisoning them, or C, blood is leaching from the bones? The answer is C. Lead can actually leak out of the bones back into the blood once the blood lead level goes down. Why does blood get into the bones? Well, essentially, it looks and acts exactly like calcium in the body, and as you know, your bones love calcium, so if your lead levels are high, the lead will be taken up into your bones instead. Pediatrics asked you to x-ray your cousin's arms. Seems like a weird request, right? He hasn't fallen, he doesn't have joint pain, but actually the reason for this is to determine acute versus chronic exposure. If you've been chronically exposed, as I said, you can actually see where the bones took the lead up on the x-ray. These are bright white lines called lead lines. All right, back to our patient. He's definitely sick. He definitely has lead encephalopathy. So you order IV calcium disodium EDTA and intramuscular dimercaprol injections. He gets admitted to the pediatric intensive care unit for more treatment. After your shift finishes, you go up just in time to see the endoscopy. After your little cousin is sedated, the gastroenterologist passes a tiny endoscope down into his stomach, maneuvers the camera around until the swallowed foreign body comes into view. As soon as you see it, you know exactly what it is, even before he pulls it out. It's a Civil War era musket ball. These are almost completely made out of lead, and it's pretty big compared to your cousin's little stomach and seems to have gotten stuck. While we wait for the chelation to do its job, let's talk about some cool stuff associated with lead toxicity. First, bullets. With our dark humor in the emergency department, we jokingly refer to gunshot wounds as acute lead toxicity. Question number 6. Bullets are removed from most gunshot wound victims. A, true. B, false. The answer is actually false, and I'm sorry if you answered true. That answer kills me every time because it's one of my most hated movie misconceptions. Digging bullets out of people who've been shot. I've treated hundreds, if not thousands, of gunshot wound victims. I've never dug a single bullet out of anyone because we don't do this in the emergency department. Why not? because cutting open the person and digging around often causes more harm than good. There are a few exceptions to this rule, and one of them is if the bullet ends up in a joint or if it later migrates into a joint. Why does this matter? Well, bullets are made of lead, obviously, but if the bullet is left in the skin or the muscle, the lead stays in the bullet and nothing happens. However, your joints are extremely acidic, and if the bullet migrates into the joint, then acid causes the lead to leach out from the bullet. Patients can and do become lead toxic as a result. And that's why your cousin was having so much trouble. Had the lead musket ball passed through his gastrointestinal system and had he pooped it out in a few days, he probably honestly would have been fine. But because it stayed in the stomach, the acid from the stomach continually leached it out, kind of like a delayed release pill. Lead on the periodic table can be hard to find if you don't know what you're looking for because the chemical symbol is Pb. Lead toxicity is often called plumbism. Why? Well, this actually has to do with ancient Rome. The Romans used lead pipe for plumbing, and that's how it got its name. Excavation of bones from ancient Rome show very high lead levels, and there's a distinct difference between the bones of patricians, the upper class, and the bones of enslaved people. The patrician bones have high lead levels, the enslaved people don't. What's the difference? There was a relatively high amount of lead in the water because of the lead pipes. There was also lead in the air from smelting and mining. Had lead levels been coming from environmental sources, then you would imagine that everybody should have had the same exposure. The answer is actually a lot more interesting. There was lead in the wine in ancient Rome, not accidentally, but put there intentionally. Everybody knows the Romans loved wine, right? In fact, it's estimated that adults in ancient Rome might have drunk as much as 5 liters of wine a day. Specifically, they liked sweet wine. How did they make it sweet? Well, they didn't have sugar or corn syrup. Those are New World items. They did have honey, but given the copious amount of wine people consumed, it would be difficult and expensive to make that much honey. So what did they do? They sweetened the wine by adding a syrup called sapa, made from grapes. Essentially, the grapes were boiled down into a syrup, specifically in lead-lined pots. Grapes became vinegar, and vinegar plus lead results in lead acetate, also called lead sugar. The Romans put the sapa into their food and their wine to sweeten it, resulting in extremely high blood lead levels. It's estimated that sapa contains 29,000 parts per billion of lead. Compare that to what's considered safe in water today, which is 10 parts per billion. By some estimates, patricians in Rome may have had lead levels as high as 50 micrograms per deciliter. And some historians have suggested that lead toxicity was the cause of the fall of the Roman Empire. Is this true? It's definitely a fun topic to think about. But first, let me tell you some of the other symptoms of chronic lead exposure. It can cause a huge number of symptoms, including fatigue, headache, irritability, impaired concentration, memory loss, mood swings, intellectual disability, tremor, peripheral neuropathy, and extremity weakness. Also, infertility and increased infant mortality. Historians have questioned whether Roman emperors exhibited symptoms of lead toxicity. Caligula was described as having disorders of the intellect. He was known to have seizures and definitely had psychosis. Claudius was described as having weak limbs and unsteady gait, a tremor, and mental instability. Nobody knows for sure, of course, but certainly some of the descriptions do fit with lead toxicity. As the Roman Empire declined, the emperors developed erratic decision-making and suffered from infertility, leading to further speculation as to whether or not lead toxicity itself caused the fall of the Roman Empire. Lead toxicity certainly could have contributed to lower IQs, unstable mental status, and reduced fertility. However, it doesn't totally explain things like weakening of the central government, attacks from barbarians, etc. So it's pretty cool to think lead might have contributed, but historians doubt it's the only explanation. Most lead toxicity in the United States occurs from children eating paint chips. Lead paint has been banned for use in houses here since 1978, so we see it in children living in older housing stock in the northeastern part of the United States or in some areas of California. Other sources include pottery with lead glazes. If you've ever bought a ceramic pot that says "don't eat out of this," that's probably the reason. Spices from outside the United States can have lead. Turmeric is a common one for some reason. It can be in makeup, again, from outside the US, like Kohl eyeliner. Supplements have been found to contain lead. Environmental exposure, of course, like drinking water, most recently in Flint, Michigan. In developing countries, people are at risk in areas where smelting and mining occur. Occupational exposure is definitely not uncommon. One interesting one is employees at firing ranges. Because there are so many bullets, if they don't take appropriate PPE precautions, they may develop lead toxicity. And another topic is leaded gasoline. So tetraethyl lead was put in gasoline to avoid knocking sounds coming from the engine. This resulted in massive environmental contamination. In the late 1970s and the 1980s, it was phased out in the US, and since that time, the average IQ of American children has risen by 9 IQ points, which is really kind of fascinating. We've talked a lot now about lead toxicity, but we actually haven't talked about the mechanism. We don't know all the details, but we do know it affects multiple pathways and parts of the body. It can cause reactive oxygen species. These are highly reactive and bind to receptors, proteins, and DNA, causing cell malfunction. As I said before, it acts like calcium and is taken up into cells instead of calcium. In addition to bones, this actually has a big effect on neurotransmitters in the brain, contributing to encephalopathy. It inhibits heme synthesis, resulting in anemia. Not only is the history of lead toxicity interesting, but so is the history of the chelators we use to treat it. Dimercaprol, for example, as I said earlier, is also called British anti-lewisite. Why the old name? Well, at the start of World War II, the British were extremely concerned about the Nazis using chemical warfare, and one of the concerns was the use of arsenic gas, which they called lewisite. Researchers at Oxford discovered dimercaprol as an antidote, thus the name British anti-lewisite. Later, it was found to be useful for chelation, including not just arsenic, but also for mercury and lead. Treatment of lead toxicity is already complicated, as I said earlier, but this has recently become more difficult as the only American manufacturer of dimercaprol filed for bankruptcy, leading to severe shortages in the US. Another chelator called DMPS is used in Europe, but it's not FDA approved here. It can be made by compounding pharmacies, and it is useful for lead toxicity, but it's not currently recommended for lead encephalopathy. Back to our patient. The PICU team repeats a blood lead level later that evening, and thanks to removal and chelation, it drops precipitously, and because it's acute rather than chronic toxicity, the lead is not in his bones and his lead level stays down. By the next day, he's back to his rambunctious self and fortunately is discharged from the hospital with no permanent neurocognitive deficits. At the next family party, you make sure Grandpa has the Civil War musket balls locked up and away from the children. This is a fictional case, as are all our cases to protect the innocent, but it is based on real poisonings. That brings us to the last question in today's podcast. There's a very interesting study in England in 1975 when leaded gasoline was still prevalent, showing the average amount of lead on post-mortem exam was 165 milligrams, i.e. the weight of a paperclip. How much lead was found in men diagnosed with lead toxicity, i.e. how many paperclips was the equivalent? Did the men with lead toxicity have the equivalent of 3 paperclips, 10 paperclips, or 100 paperclips? Follow the X and Instagram feeds, both at PicPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at picpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.